Hello, my name is Dr. Ukiri Richard. I continue my podcast today on basic cardiology. Today we are going to talk about redness and swelling of the lower leg. The case we are using today is that of a 39-year-old farmer that noticed the redness and swelling of the left lower leg without any known cause, and he has been having some fever and also left pedal edema. My question, first of all, could you tell me differential diagnosis of one-sided leg swelling or one-sided pedal edema? Well, the one-sided pedal edema could be either a phlebologic cause, could be lymphedema or orthopedic cause. In the phlebologic cause, it could be either deep vein thrombosis, could be thrombophlebitis, varicosis, post-thrombotic syndrome. Then number 2, it could be lymphedema, or number 3, orthopedic causes like Becker cyst, morbus Zudek disease, muscle tendon tear, or joint effusion. What would you need in the history now to narrow to lead you on to your diagnosis? Well, in the history, I will check out for history of varicose veins. I will also see if there's any history of venous sicknesses in the past. I will ask for joint pain. I will check if the patient usually took a long distance travel, that is to check if there is thrombosis after a long distance flight or long distance travel with car or bus, and I will check if there is a travel to a tropical area in case of a filarial infection. That is good. So now you want to examine the patient clinically. What are you going to look for particularly in the clinical examination to help you to get to your diagnosis? Well, the clinical examination I will focus on will depend on what I'm thinking. To exclude or when I suspect a deep vein thrombosis, for example, I'll do Homan signs. That means I'll look for tenderness in the calf on dorsiflexion of the foot. I will also look for Peyer's sign, that is P-A-Y-R-O, Peyer's sign, that is tenderness by compression of the sole of the foot. I will also check for reduced calf ballottement. If I suspect a chronic venous insufficiency, the signs I will look for in a physical examination shall be, I will look for varicosis, I will look for signs of congestion eczema. Then if I suspect lymphedema, the things I'll look for, the signs I'll check in the clinical examination will be 1. That's what you call this Stemmer sign, that is S-T-E-M-M-E-R, Stemmer sign. In this case, the skin fold over the toes are thickened and cannot or only slightly be lifted. 2, I will check for, in case of the lymphedema 2, for involvement of the foot. And 3, I will check for enlarged lymph nodes. But I would like to say that in all the differential diagnostics I've listed above, none of these signs will be able to pin down a diagnosis completely. It's good, okay, it's good that you just said that. Now, what diagnostic test or what's your next diagnostic step that you will now carry out? Well, basically, I will need laboratory tests, sonography, and in case of doubt, I will do sequential sonography after 2 to 3 days, phlebography or CT angiography. In the laboratory test, I will look for D-dimer, which has a high sensitivity but very low specificity for the diagnosis of a phlebothrombosis. Negative result has practically excluded a phlebothrombosis. In the sonography, especially the compression sonography with two-mode linear probe, 7.5 millihertz, with right angle to the vascular lining. You are going to get a very high sensitivity and specificity for diagnosis of a deep vein thrombosis. To judge the inferior vena cava and the iliacal and femoral veins, the FAB color coding has been proven to be useful. Through this sonography, you could also get differential diagnosis like, for example, Baker cyst and muscle tendon tear. As I said, in case of doubt, you do sequential sonography after 2 to 3 days, phlebography or computer tomography angiography, that is CT angiography. Okay, now let me update you. You did a sonography where you could not see any findings suggestive of a phlebothrombosis. Contrarily, in the clinical examination, you found signs suggestive of lymphedema. My question now is, I would like you to name the causes of a secondary lymphedema. The causes could be in 5 groups: infectious, tumor, lymph node resection, radiation, and traumatic trauma to the lymph tracts. In infections, it could be recurrent erysipelas or filarial infection. In tumor, you could have lymphoproliferative diseases, lymph node metastasis, blockage or disturbance of the lymphatic flow in the waist region. In the lymph node resection, it could be, for example, after axillary lymph node resection due to a breast cancer. You could also have secondary lymphedema after radiation, and you could also have secondary lymphedema after traumatic injury to the lymphatic tract. For example, post-operatively after saphenous vein extraction for coronary artery bypass operation. So now you went back to ask the patient again the history, and the patient told you that he has had this kind of symptoms before and that subsided after some time. And when you went to take a good physical examination at the digit, you saw interdigital mycosis in between the toes. My question is, what do you think is the most likely or most probable cause for this lymphedema? Well, in this case, it's very clear. I think it's a recurrent erysipelas. Good. That's very good of you. Now, what are you going to do therapeutically for this patient? Well, if there are signs of a fresh erysipelas, I will give antibiotics, and the preparation should actually be effective against streptococcus and staphylococcus. For example, flucloxacillin, amoxicillin, clavulanic acid. I will also sanitize the interdigital mycosis. I will do symptomatic management of the lymphedema through manual lymph drainage. And when this is ineffective, I will give a compression stockings that should be worn during the day. Then I will give a standby antibiotics preparation that should be carried out when there is a recurrence of the erysipelas. Okay, let's make a diversion now about bilaterally leg swelling. What differential diagnosis do you know that can cause bilateral leg swelling? Well, let me grade them into 6. It could be cardiac, it could be phlebologic, it could be hypoalbuminemia, it could be medication induced, it could lymphedema and also other causes. In the cardiac causes, you have, for example, cardiac failure, valvulopathy, cor pulmonale, pericarditis, pericardiac effusion, hemodynamic relevant AV fistula. In the phlebologic causes, it could be bilateral varicosis, could be chronic venous insufficiency or post-thrombotic syndrome. In the hypoalbuminemia, it could be either nephrotic syndrome, liver cirrhosis, exudative enteropathy, or malnutrition. It could also be medication effects, side effects. It could be lymphedema, for example, bilateral lymph congestion due to lymphoma. Other causes could be pregnancy, myxoedema due to hypothyroidism. Which medications do you know that could have edema as side effects? Calcium antagonists from dihydropyridine type, for example, amlodipine and nifedipine, are popular for these side effects. Also, clonidine, hydralazine, minoxidil, and non-steroidal anti-rheumatic drug, that's NSAIDs, steroid, estrogen, and glutathione. They all cause this bilateral leg swelling. Also, I forgot guanetidine. Good. How do you differentiate leg swelling from cardiac causes and those from hypoalbuminemia? It's easy. Leg swelling caused that have cardiac origin usually involve the legs and get worsened during the day. Edema from hypoalbuminemia manifests mostly during the early hours of the day and affects also the faces and the eyelids as well as periorbital region. So my last question is now, how can you use a rational laboratory test to confirm a renal cause of a pedal edema? Well, this can usually be done by measurement of the serum albumin, serum creatinine, and urea, as well as the protein secretion in urine. Thank you very much.